Hello, everyone. My name is Yara Salman, and I am a psychiatrist at a cancer center called City of Hope in Los Angeles, California. And it's an honor and pleasure for me to be here and talk to you about emotional distress in patients with cancer. And although my talk will be primarily focused on symptoms of anxiety and depression, I do want to talk more broadly about the significance of emotional distress in general. When I first came to City of Hope and I saw the quote that you can see a picture of on this slide that says, "There is no profit in curing the body if in the process we destroy the soul," I felt that City of Hope understands what I do as a psychiatrist. And I do feel that the appreciation of the importance of mental well-being and mental health for our patient population is highly valued at City of Hope. As you may have witnessed yourself, having cancer can be a stigmatizing diagnosis to have, although I think over the years that has improved. In addition to cancer, having a diagnosis of depression and HIV can be additional stigma. So sometimes our patients deal not with one, but two or triple stigma that makes their condition even more difficult. I don't think I would be doing the work that I do every day without people and pioneers in the field that came before us. And I want to particularly highlight the name of Dr. Jimmy Holland. Some of you may be familiar with that name. She has done some work in promoting psycho-oncology even on the African continent. And her and my colleague, Professor Matthew Loscalzo, have been one of the main editors of a textbook on psycho-oncology. There's a picture of the textbook on the slide, and I hope that some of you can have access to it because it's a very useful source of information, not just for psychiatrists, but anybody who works in the field of oncology. And Dr. Jimmy Holland was really a pioneer in establishing the importance of psychosocial care and paying attention to psychosocial concerns in cancer patients, and really highlighting the importance of the human side of cancer. Another one of my mentors is Dr. Marion Cohen, also a psychiatrist who has been one of the founding experts of HIV psychiatry. And maybe you're familiar with her textbook on psychiatry for patients with HIV and AIDS. Now, if you're wondering what psycho-oncology means and where it's coming from, it may help to give you a little bit of an overview of the history of this field, particularly in the United States, but now psycho-oncology is well established all over the world. As you know, in 19th century, having a cancer diagnosis almost inevitably meant that patients would receive hardly any treatment and would die. So they considered the diagnosis of cancer to really be the equivalent of a death sentence. But then with early 20th century and advancements in treatment, particularly surgical treatment and radiation treatment, as well as with the establishment of the American Cancer Society in 1913 in the United States, and then subsequently first chemotherapy, cure of cancer, with the advancement to combine modalities of treatment, We started to see, particularly in the 1960s and 70s, with the kind of the rising of palliative care field, um, the sort of the birth of psycho-oncology, the field of psycho-oncology. And then in the late 2000s, the Institute of Medicine issued a report on cancer care for a whole patient, where they really spelled out the importance of attending not just to the physical, to the medical aspect of cancer, but really taking care of the whole person and taking into consideration the psychological and psychosocial aspect of having cancer and being a cancer survivor. The National Comprehensive Cancer Network recognized that many patients who have cancer experience some degree of emotional distress, and they wanted to figure out how we can best recognize it, what can we do about it, and they came up with the term distress as sort of the most suitable compromise in naming the psychological experience that patients have, because some of the other terms like depression or anxiety can feel and seem so stigmatizing. Now, we realize that there are times during patients' experience with cancer when distress can be particularly significant. And of course, it's very individual and it's not the same for every patient. But oftentimes, those are periods right after the diagnosis, sort of the shock of the diagnosis, the initiation of treatment, then end of treatment, and having to kind of move on and going from maybe more frequent visits to the doctor to less frequent follow-up, fear of recurrence and actual recurrence of cancer, or transition to palliative care, and of course, periodically during the time of remission. The stress screening is important. Proactive distress screening is important because our patients may not be willing or able to really share spontaneously how they're doing psychologically. They may either feel that this is not something that they should be talking to us about, or they may feel ashamed to admit that they're struggling. So they may put on this happy face for us and for their families to show that they're okay, when really internally that's not how they're feeling. As far as the psychological response, it can really range from what we might call normative distress, so some degree of worry, sadness, grief is appropriate, acceptable, and very common. And these feelings can last for a few days, for a few weeks, they can come and go, and eventually they can resolve as people adjust. But for some patients, they can actually persist and worsen and evolve into something more serious that could actually be considered to be a mental health disorder or a psychiatric disorder. One of the most common diagnoses that we use in when evaluating patients with cancer is a diagnosis of an adjustment disorder. It's really a type of diagnosis to describe a patient who is struggling emotionally, they are distressed, but it's not necessarily a more serious psychiatric diagnosis such as clinical depression or significant anxiety disorder. Now, patients may develop those disorders eventually, but maybe not. Maybe they're having trouble adjusting right now, but with appropriate intervention, maybe spiritual counseling or some therapy, they can get better and they will improve. However, if we ignore it, if we say, well, it's appropriate to be distressed, it's appropriate to have some kind of emotional struggle, what may happen is that these patients may experience less satisfaction with their overall cancer care. They may experience a desire for hastened death. They may wish to die sooner. In some of the states in the United States and some other countries in Europe, it's possible to ask for physician physician's assistance in dying when the physician prescribes medication that the patient takes and actually ends their life that way. So where that is accessible, patients may ask for that more promptly because they're so psychologically distressed. They may also feel like their quality of life is struggling. And of course, the distress is important not just for the patient, but can sort of spill over to family members as well, who themselves may be struggling. Perhaps you're familiar with some of the screening instruments for depression and anxiety. If you wanted to proactively screen your patients for depression or anxiety, there are several instruments that have been validated and used, and this is just an example of a couple of them that are actually available on the internet for free in different languages. But you want to use them only in the situation where you feel like you have resources to help your patients should they really be experiencing clinically significant anxiety or depression. So you don't want to just screen, you also want to be able to do something about it. Now, I will talk a little more about depressive disorders and anxiety disorders, but I want to sort of point out that the diagnostic criteria and the way that we describe them in the United States and Northern America is based on the DSM-5, so Diagnostic and Statistical Manual. In Europe, the ICD-10 is primarily used. It's very similar to the DSM-5, but I want to be sensitive to perhaps your environment where you may have different experience with how patients with depression present that can be really determined by their cultural environment and present in a somewhat different manner than what we see here. And I bet that you yourself could teach me a lot about how patients with depression present in your circumstances, in your situation. So based on the DSM-5, the diagnosis of MDD or major depressive disorder occurs in about a quarter to third of patients who present with depressive symptoms. So almost half of the patients with cancer will have some depressive symptoms at some point, but about a quarter of them actually meet the criteria for a clinical diagnosis of depression. And as I said earlier, if you're going to screen, you want to be able to respond to positive screen. Sometimes, or in many cases, it really is enough to ask one simple question that can tell you whether patients might be struggling with some significant depression. And that is asking the patient if they've been feeling down, depressed, or hopeless most of the time in the last 2 weeks. This is a highly sensitive question that can capture patients who may have more serious difficulties with their mood. Now, of course, when you have somebody with depressive symptoms, you want to think about the differential diagnosis. Depressive symptoms could indicate that the patient may be struggling with a substance use disorder, for example, alcohol use disorder or excessive opioid use disorder. Or if you have a patient in the hospital setting, they could present as apathetic and depressed when in fact they are experiencing a hypoactive delirium, which is a medical condition that requires a completely different approach. Other psychological conditions that can present with depressive symptoms but are not necessarily a major depressive disorder are demoralization or complicated grief. And so we want to be able to discern which one of those conditions may be causing the patient's symptoms if they're present. Of course, you want to take into consideration the possible effect of chemotherapeutic agents. Some of them can cause depression for patients, or medications, or metabolic or endocrine and nutritional disorders. And you would do that by obviously reviewing the patient's medications list and also doing some basic laboratory workup. Here's an example of a patient that we commonly encounter, or fairly commonly encounter, this is a middle-aged Black woman originally from South Africa who was diagnosed with metastatic breast cancer and is referred to psychiatry because she's been struggling with significant anxiety and depression. She's very concerned because she's the main breadwinner of the family, meaning she's the main source of income for her family. She has 2 teenage children. Her husband has not been very supportive and her marriage is not very good. She has a personal history of being raped as a young girl, and that's how she contracted HIV. So she's already had this diagnosis to deal with. And because of her past experiences with healthcare, she's coming to us with a sense of kind of mistrust and worries about whether we're really going to be able to take good care of her. She's experienced discrimination firsthand. So, turning it back to you, what kind of concerns would you anticipate when you meet a patient like that? And you could say, well, a broad range of concerns, anything from is she going to trust her doctors and be able to adhere to treatment, to could some of the aspects of treatment be triggering her memories of the trauma and complicate her ability to participate in treatment? Could patient maybe end up avoiding coming to her appointment? How is she going to sleep and take care of herself when she's worried about how she's going to support her family? And who's her support if her husband is not very supportive? So you can already see how layered that psychosocial aspect of cancer care is, and so individualized because it varies from case to case. This slide lists the diagnostic criteria for a major depressive disorder. In order for us to assign this diagnosis, patients obviously have to meet the required criteria. A lot of these symptoms are symptoms that are physical, that could be due to the cancer itself or the treatment of cancer. But regardless of the etiology of these symptoms, we do count them in when we make the diagnosis. So in other words, even if the patient has low appetite because of the cancer or the cancer treatment, if they have the changes in their mood that are significant and have been going on for more than 2 weeks, we do count that symptoms of low appetite in for the diagnostic criteria. For patients who come to us, sometimes it can be really challenging in a busy oncology clinic to diagnose someone with depression. Part of it is that patients don't bring up those symptoms. They feel like they should really, tell the doctor mainly or only about their physical symptoms. Sometimes they don't bring these things up because they feel that having a mental health diagnosis would be very stigmatizing, or they're afraid of taking any psychotropic medications. There could be a myriad of other barriers that can be cultural or gender or age related or language and so forth. Sometimes patients don't want to talk about their sadness or their worries because they feel the pressure of staying positive. And they feel that if they disclose how they really feel, that might imply that they're not fighting, that they're not in a fighting spirit. Now, if we don't treat depression, if we just say, oh, it's normal to be depressed, it's understandable that you're depressed, everybody would be, but the patient is depressed most of the time for a prolonged period of time, they're going to have a harder time understanding and processing the information that you are giving to them. As I mentioned earlier, they may have a desire for suicide or die sooner because of perhaps low appetite. They may not be eating well. You as an oncologist may decide that you need to lower their chemotherapy medication, and that will have an impact on the overall cancer treatment. Chronic depression can impact our immune system. It can lead to poorer quality of life, increased physical symptom burden. When people are depressed and feeling down, even their perception of pain is heightened, right? They may have lower adherence to your recommendations. If they're depressed, they might not show up to your appointment. They might just stay home because it's hard to get out of bed. So untreated depression can have serious consequences for their overall cancer treatment and success of cancer treatment. Anxiety is also very common in patients with cancer, whether that's anxiety that has been there even before the diagnosis of cancer or something that came up with the diagnosis of cancer. As you know, a lot of our patients worry about things that people without cancer may not necessarily think about, and that is prognosis, right? Am I going to survive this? And if I am, how long am I going to live? Is my cancer going to come back? That's a very, very common source of anxiety for our patients. They have anxiety about the effects of treatment. If they have to undergo treatment, what does that mean for their ability to work and to fulfill their other life roles, to function as a parent, as a partner, and so forth? A lot of our patients struggle with transportation. They may not have means to get to the clinic to come for their treatment. And many are bothered by their dependence on others. You know, oftentimes, particularly patients who are used to being the helpers, being the ones who are taking care of other members of the family, it can be really hard for them to be in the position where they are the ones needing help. Now, back to our case of Angela, who already finished her chemotherapy. She had her surgery with breast reconstruction, and then she comes back again to see me and is now on maintenance treatment with tamoxifen that seems to be worsening her mood. She is constantly worried about her cancer coming back. And in addition, she now feels really poorly about her body and worries about how that's going to impact her relationship with her husband that's already been strained. So think about, what would you do for this kind of a patient? What could you do for this kind of a patient to address her concerns? And these are very common concerns that patients bring up. Again, I don't want to go into details in terms of different categories of anxiety disorders, but there are different forms of anxiety that can cause distress and difficulties for patients and impacting their ability to participate in treatment, whether it's a panic disorder with recurrent panic attacks or specific phobias, for example, phobia of needles or claustrophobia, so patients will have a hard time getting into a CAT scan, for example. And some of our patients can experience cancer and cancer treatment as traumatic, and they may have some symptoms of a post-traumatic stress disorder afterwards. Maybe not the full syndrome, but some of the symptoms. Again, if you have a patient who presents with anxiety symptoms, you want to think about your differential diagnosis and other possibilities that can lead to anxiety. For example, some of the medications or respiratory conditions or withdrawals from substances, they can present with anxiety. So, of course, depending on the cause, you will then determine your treatment. Now, what can you do, being the nurse or the oncologist on the front line? I think that being willing to listen, to spend a few minutes, really just a few minutes, to empathetically listen to your patient and validate their experience, letting them know that you understand, that you may not know exactly how they feel, but you can understand how they feel, and that you've seen that before, and that they're not the only ones feeling a certain way. That can go a long way for people to feel that you heard them and that you understand how they feel. That in of itself is therapeutic. That in and of itself helps patients to feel better. You can educate them about the common experience with worrying and depression, and that you care about that, and that you want to hear them out and maybe do something about it if it's necessary, if it's significant. Perhaps refer them to a support group. And in my little research that I've done on what kind of mental health support there might be in Uganda, I came across this organization called Strong Minds, which is a nonprofit that organizes support groups for women, poor women in Uganda who struggled with depression. Being in the group of patients who have similar experience, and they support each other and hear each other, is incredibly empowering and incredibly therapeutic. Perhaps there is an opportunity to refer to couples counseling. Sometimes a couple just needs 1 or 2 sessions to talk about, their problems and learn some new tools, and that can be tremendously helpful. Spiritual counseling for some patients who are open to that. And then, of course, there are medications that if you have any of them, available, if you can prescribe them for patients and they can access them, they can be very helpful. And I would recommend maybe at a later time that you review these slides on pharmacotherapy and think about maybe 1 or 2 agents that you either have been using or want to get comfortable using. The most important thing is that you really have patients on a high enough dose and a long enough time, because the antidepressants do take time to work, usually a few weeks, for both depression and anxiety. They're not addicting, they're safe. If you have a patient on tamoxifen, for example, you probably want to go with venlafaxine as your first line treatment for depression or anxiety, because it does not have any drug-drug interactions with tamoxifen. These are some of the general principles that I have mentioned that, again, you can review on your own time and refer back to when you need to prescribe. One other point that I like to make whenever I talk to others about emotional distress in patients with cancer is that we as physicians, as nurses, we want to maintain a sense of cultural humility. And that means that we want to be open to learn from the patient about who they are, what's their background, what kind of experiences they have had. Here in the United States, the research has shown that people who are from non-majority groups, so people of color or maybe some other ethnic groups, may feel less satisfaction with treatment. They feel like they're less involved in decision making, and they have a less overall trust. And the disparity can be exacerbated by linguistic, ethnic, or racial discordance between patient and the doctor. And it can go both ways, so even as physicians, we have to be mindful of our own personal bias, be aware of that, and be aware of how that may interfere with our ability to provide good care for patients. As a psychiatrist, I am very familiar with how stigmatizing psychiatric disorders or mental health issues can be for patients, that they feel reluctant to even come to see me. Or when they come to see me, they're reluctant to be on medications because it's stigmatizing, and their family members may be against that. Again, I want to acknowledge that the depression itself is a concept that is pretty accepted within Western European and North American societies. But the depression as a syndrome, as a universal experience, but the way that it presents clinically may really vary from culture to culture and from place to place, because in some cultures, it is the physical symptoms that may be predominant: headaches, stomach aches, fatigue, and so forth. So we want to be mindful of that as well. And that was my last slide, and we have maybe a couple of minutes for questions.
Well, hi. I'm going to comb my hair again. I'm Ken Miller. I'm a medical oncologist. And Yara, thank you so much. That was a wonderful talk. And really a reminder of how common some of these problems are, and also how commonly many of us, other than perhaps people that are very sensitive to it, how often some of us, including myself, don't necessarily delve into it and ask patients their emotional experience. And there's a lot of reasons for doing it, including time and worry that I may not have the answer, etc. So anyways, thank you. Wonderful talk. We did get some questions, some email questions as you were speaking. So we actually got two that are that I put together. One was from a colleague in Tanzania, and one was from the Ivory Coast. It was talking about emotional distress, and in a sense, what's the timing of that? And I wanted the two participants in our conference, one was asking about sort of at the beginning, at the time of diagnosis, and another one was actually asking on the tail end of that, when people are finishing treatment, let's say are in remission, what's an amount of time that would be common, and what's an amount of time beyond which you start to say, hey, this is becoming a problem?
Mm-hmm. So as far as when emotional distress can occur, you're absolutely right, or the colleagues who are asking about this, it can be really at any point on the cancer trajectory. If you think about a patient who has been pretty healthy and all of a sudden they have some physical symptoms, they go to the emergency room and they're told that they have leukemia, it's a pretty shocking and devastating thing to happen. So of course they're going to respond with distress. It's not uncommon for people to sort of brace themselves for the treatment after the initial diagnosis, get through surgery, get through chemotherapy. And it's not until after those treatments are done, when they finally have some time to think about what they just have gone through, what they've experienced, and that's when it dawns on them. And that's when they get referred to us, because they're all of a sudden dealing kind of with the emotional aftershocks of treatment. Or it's patients who come, let's say, 6 months or a year into their cancer diagnosis, when they're still recovering and they're not getting back on their feet the way that they expected. Right. So it could be at any point. As far as the duration of symptoms, for depression, the symptoms really need to last most of the time for at least 2 weeks. So it shouldn't be a few days, here and there, and then we diagnose clinical depression. So at least 2 weeks, most of the time for depression. For anxiety, I would say also, for a few weeks, really kind of a persistent, distressing anxiety. And really, a disorder by definition is something that's causing significant subjective distress for the person and or impacting their functioning. So because of their depression or because of their anxiety, they're having a hard time functioning in their life. And it could be that they're having a hard time participating in their treatment, or getting back to work. So I hope that answers the question, but I think it's a very valid and important question.
Yeah, thank you. Actually, I wanted to ask as sort of maybe the flip side of that. There's talk about post-traumatic growth syndrome. Really, people not only bouncing back, but bouncing forward after cancer. Can you share a little bit about that? And along those lines, is there anything that we as oncology professionals and as an oncology team can help people bounce forward?
Yeah, there's actually some research looking into the so-called post-traumatic growth. So The idea is that patients or people can experience some significantly traumatic, perhaps, as cancer can sometimes be, or life-changing event, and they can come out of it um, um, sort of spiritually improved or grown, and they feel like they've learned something through that experience. And I have seen it in my patients who will say, you know, I am a better person now because cancer taught me what's important in life. So it's kind of like having that experience allows them to change their perspective on many aspects of their life, and they appreciate that. They would not want to have cancer again, of course. They feel like that experience has been actually life-changing in a positive way. I do think that that may be rooted in who that person is to start with. So I think a lot has to do with kind of perhaps their individual attitude and their ability to have that perspective. But I do think that as oncologists or psychiatrists, we can sort of gently maybe nudge that, gently encourage that, because we don't want to do too much of that so that patients don't feel like they're dismissed. You know, if we tell them, well, cancer is bad, but look, you know, now you know what's important in life. We don't want to sort of feed it to them, but we can help them to you know, steer them in that direction, perhaps by asking them questions. What's important to them, how they may be seeing their life differently now, you know. So we want to be careful in kind of meeting that person where that person is at their sort of a spiritual evolution, so to speak.
Yeah, thank you. We had a question from again on this topic of emotional distress, and this was a colleague from Nigeria, basically writing in their email that sometimes the distress seems to be not proportional to the severity of the illness, but inversely proportional. And I can tag team on that a little bit myself. I've seen women with, let's say, for example, DCIS, who's non-invasive breast cancer, whose level of worry sometimes is more than my patients that have, you know, multiple lymph nodes involved. What are your thoughts on that? What, you know, and again, how can we be of help to that patient and family where again the level of worry is more than is significantly more than what medically we may have thought of?
Yes, you know, I think that we see those kinds of patients all the time, and you could almost say that sometimes that, you know, the stress is in the eye of the beholder. So what we may, with our knowledge, we may perceive as this is a low risk illness. You know, there's no reason for you to be so worried. The patient themselves individually may be prone to being excessively worried. So I would suspect that maybe that's part of their sort of individual makeup. This could be somebody who's already had other stressors in their lives. So that it's almost like they're kind of primed to worry more. So again, I think if that excessive anxiety persists and is really causing a struggle for a patient, we could recommend some additional help, whether that's group counseling or individual counseling, obviously, if that is available, if that's possible. Sometimes I think the oncologists, or maybe oftentimes, they have to kind of walk that fine balance between, you know, being reassuring, being encouraging, but at the same time, sensitive to the patient's level of distress. So sometimes that balance, it's harder to keep when patient is excessively more anxious than you think is appropriate. But acknowledging that and continue to reassure them and let them know you will keep an eye on them, you will follow up with them, you will, make sure that you'll catch anything that, maybe going on, maybe reassuring in and of
Yeah.
itself.
There were two questions that are from two different participants, and there's sort of the same theme here. One of them asked, does discussing death or the possibility of death make patients depressed? And the other one asked, does this, if, for clinicians that are worried about a suicide risk, does discussing suicide make it happen?
Those are great questions. So I'll start with the second one. The research has shown that the answer is no. So discussing suicide with patients does not make them more suicidal or does not increase their risk of suicide. In fact, I think it can be helpful if we proactively ask patients about that, because it's a relief to them to hear that we're not scared by those thoughts, should they have them. And, as a psychiatrist, I ask that question all the time. And I have not had a patient who would be upset about being asked that. So, yes, I think it's important that we ask openly about the concerns that we have. It's similar to asking patients about, maybe sexual side effects of medications. They may not voluntarily tell us, but if we ask them, oh, that's okay to talk about it. We kind of invite them to talk about it. And the same is about death and dying. And I think that sometimes approaching these topics is best to do with questions and asking the patients themselves, what's been on your mind? What are you worried about? Do you think about, or saying, some of my patients are worried because they worry about dying. Is this something that's been on your mind as well? And they can say yes or no. And so there are ways to invite the conversation, but by doing so, you are not going to make people more depressed or more upset. Although it may be an upsetting conversation for them, but for them to know that you are not scared to bring those topics up is very reassuring. You may be the only person that they are able to talk about this with.
Yeah, I can imagine that. And finally, one last question, and may seem like an easy one, but I think it's important to put out there. When I know for myself, when I treat patients with some cancers, I say this is a treatable and a curable disease, if that's the case. So I want to ask you the same thing for us non-psychiatrists, but for patients with cancer with significant distress, is that whether anxiety or depression also a treatable and a curable disease? What's the prognosis for, is really what I'm driving at. What's the prognosis for patients with distress?
In general, yes, we can help a lot of people. It helps to have the intervention to be individualized, meaning one size does not fit all usually. But the fact that patients are struggling with anxiety or with depression should really prompt us to try to help them within the resources that we have available to us, because helping them really gives them a chance to get better. If we say, well, it's normal to feel anxious or it's normal to feel depressed, but their suffering is really intense, then we may be actually doing more harm than good. So treatment can help in many cases.
Very good. Anyways, I would like Yara, thank you so much. Actually, a wonderful talk, and you went over some really important topics.
Thank you. Thank you for the opportunity. I appreciate it.